Hi, everyone. We'll get started in about 30 seconds. Hello, and welcome to the webinar, Not All Uterine Cancer is the Same. What to know about rare uterine cancers. My name is Kitty Silverman, and I'm the Uterine Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. We have a few housekeeping reminders for you. All participants will be muted during the presentation. Once the speaker finishes her presentation, we'll begin the Q&A discussion. Feel free to ask any questions through the Q&A section at the bottom of your screen. Remember that Dr. Lee is unable to give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. This webinar is being recorded. We'll share the recording in a few weeks with all registrants, and it will also be added to our website. Now I'd like to hand it over to today's speaker, Dr. Nita Lee, to introduce herself. Thank you, Dr.
Thank you. Thanks everyone for being here. Thank you for the opportunity to talk today. I think this is a really important topic because I think there's sort of this impression about uterine or endometrial cancer, and we've just learned so much more about how it is not one disease. And we've always sort of known this in kind of in the clinical setting, and I think it's just really important to be able to talk through this. I'm a GYN oncologist. I'm at the University of Chicago. I specialize in both the surgery and chemotherapy and sort of the longitudinal care of women who are diagnosed with GYN cancers. I direct our fellowship program, and I serve in our University of Chicago Comprehensive Cancer Center as the Assistant Director for Community Engagement and Outreach. And through that, I do a lot of community-based talks, but also a lot of community engagement, especially with patients who are interested in sharing their own story and becoming advocates either for education or research or policy. And so I'm really excited to be collaborating with Share Cancer Support because I think they do a great job. And if anyone ever wants to reach out about ideas and different things like that they may have, and I know that this group and I would be more than willing to kind of listen through all of this. So I'm going to go ahead and share screen, I believe, and get started with everything. And again, bear with me. I did practice on sharing this and just making sure that you're going to see the correct slideshow mode. And if Kitty, if you don't mind making sure that you can see the correct one, or are you seeing the wrong one?
This is actually the wrong one.
Okay, all right. I'm going to get to the correct one. I apologize.
No problem.
Okay, how's that?
Perfect, thank you.
Okay, excellent, excellent. Okay, so again, not all the same. What to know about rare uterine cancers. So a little bit of the outline of today. I want to go over a little bit about the trends in uterine cancer and why it's so relevant to be talking about these higher risk types. Understand the different types of less common endometrial cancers, and spend a little time thinking about the pathology, the tumor testing, and the molecular profiling of tumor types. And this element has become a lot more important in terms of having the discussion with your physician about like, hey, what do I know about my tumor? Is it just the cell type? What are the more detailed, nuanced things that we are now learning about uterine cancer that can help us guide treatment, either treatment when somebody is initially diagnosed or treatment if somebody is facing a recurrent cancer. And I think a lot of this is a lot of terminology that I want to kind of make sure as an audience that you become familiar with, because I want you to be able to use what you learn to share with others and also take it to your own, potentially, your own physicians to kind of talk through some of these things. We'll talk through some examples of specific treatment strategies and options for rare tumors, and that kind of goes through the normal range of things that we think about, which is chemotherapy, radiation, immunotherapy, and sort of what's called targeted therapy. And I actually would like to leave a lot of room for discussion so that we can really answer your questions and get to that. So the first thing is, like, who gets uterine cancer? So in general, when we think about uterine cancer, this is generally most uterine cancer happens, as you can see here on this, I'm not sure, can you see me using my arrow? Hopefully. So most uterine cancer actually happens after menopause, with the mean age really sort of being between 60 and 65. And then you can see that there is a different distribution in terms of racial and ethnic groups as to who's most likely to get uterine cancer altogether. So the slide here that's on the left of the screen shows a bar graph of the rates of incidence rates, so new cancers. And this is kind of amplified here. So in terms of who is most likely to get uterine cancer, it's actually Black women, and then followed by white women and Hispanic, non-Hispanic, American Indian, Alaskan Native women. And so I think it's also really important to think about the trends, and we are actually seeing higher rates of cancers slowly developing over time, especially among Hispanic women. When we look at who is getting these types of cancers, particularly, we do see that especially in older women, Black women who are older, especially over age 65, are at high risk for this. And so this is just something to kind of keep in mind when you're thinking about risk factors, family members, different things like that. In general, again, most women are going to get this after menopause. So the largest chunk of women who get diagnosed, or patients who get diagnosed with the uterus, are in the 50 to 75 age range group. And I think that that's important to think about because, as we know, postmenopausal vaginal bleeding or irregular discharge is one of the most common symptoms that we see. And that's something that I tell everybody, survivors, caregivers, everyone, really make sure you know that your friends and family know that this is a symptom that really needs to get early recognition as a problem and needs to get a biopsy to get a diagnosis. Now, not all bleeding will be cancer, but it's important to rule that out. So the really important thing is that there are trends in the United States that are really striking and really important to consider. So GYN cancers, uterine cancer is the most common cancer that we see. It is actually the fourth most common cancer in women as whole in the US. And so this is really important. About 66,000 new cases will be diagnosed, and there's some estimates that are looking at like 2030 and saying that's going to be over 100,000. So we're seeing these trends of almost every 2% almost every year of uterine cancers increasing. So this has become really even more critical for all of us to understand. I think those of us who've been caring for women for a really long time, we've always thought that this is a really important area to emphasize, but I think it's becoming even more striking. And I think there's been a lot of really important attention brought to this in the news lately as well. What's really important is that, unfortunately, about 13,000 patients will die each year related to uterine cancer. And that number is actually getting very, very close to how many women unfortunately die of ovarian cancer. So it's not a competition that anyone wants to be in, but it's really important to kind of think about attention that's paid to research, to advocacy, to support. And so again, I think that's just a really important emphasis to make. When we think about the trends in uterine cancer, so you can really see that since 2000, the incidence or rate per 100,000 women has been increasing quite a bit. And it is most steep in African-American or Black women and also in Hispanic women. But we really are seeing the steepness of the rise or the slope of this going up in all women. And so this is something really we need to be paying attention to. When we looked at, when researchers looked at the rates of aggressive uterine subtypes, we really saw that rate actually is what's driving the overall incidence and the overall increase in deaths due to uterine cancer. And so that's why those cases are so important to kind of think about, both from everywhere along the continuum in terms of the biology, the diagnosis, the treatment, and the supportive care afterwards. And so I think that's really critical. And unfortunately, as you can see here, there's a disparity in terms of ethnicity and race that you can see between who's getting these cancers as well. And so I think those are really important to kind of think about, because we don't want to kind of ignore and assume that uterine cancer is a problem of only certain races or ethnicities. It actually affects any of us who have a uterus. So to kind of get into kind of some of the nitty gritty, I want to do a little bit of anatomy, sort of just like a check so that we're all on the same page, and then kind of think through the types of uterine cancer that we're going to talk about. So when we think about uterine cancer, we think about endometrial cancers are usually what makes up the bulk of those types of cancers. So that's really kind of like 90% of all uterine cancer. So this is the uterus, this is the whole body of the uterus. The fallopian tubes and ovaries are off to the side, and the vagina and the cervix are here. Sorry, I don't know if you can see this. The red splotch that I put here is in the lining. So the lining of the uterus is called the endometrium, and endometrial cancers, which are about 90% of all cancers, occur here. They grow in the lining, and they can grow deep into the muscle wall area or spread to the cervix or elsewhere. This is also where we see sarcomas. So sarcomas are different. They don't start in the gland cells of the lining of the endometrium, but they actually start in the muscle wall. And so these are kind of muscle wall cells, or sometimes the supportive cells that are in the muscle wall. And that's actually a rarer cell type, but we'll touch on that as well. There's a lot of breaking down and classifications of that, where each tumor type fits in and where each individual patient fits in. So the majority of endometrial cancers are something called endometrioid type, and they tend to be low-grade cancers, and grade refers to what the cells look like under the microscope. And so when a pathologist looks at a cell type of a cancer, they really define the grade to be either low grade, where the cells kind of look fairly typical, like the cell that they started at, but they have some features that make them cancer. And then higher grade cells that can really look quite irregular and have features in their nucleus, which is the center of the cell where the DNA rises, that look really irregular and look really funky. And the pathologists have all these different scoring systems for figuring out what the grade is. So low-grade cancers, which are sometimes often referred to as type 1 cancers, are ones that people may have heard about. They're the typical cancer that may be hormonally driven and may actually be able to be cured by surgery by itself and have a lower rate of recurrence. Then we have the non-endometrioid high-risk types, and that's about 20% of endometrial cancers. They all start in the same place, but for some reason, their biology is very different. All of these are considered grade 3, and I'm going to kind of refer to them as like high-risk types. This includes serous carcinoma, carcinosarcoma, and clear cell carcinoma. What those different 3 types are there the cells that look different. They have a very specific diagnostic look to them under pathology, and their behavior and their treatment may be different based on some of the testing that gets done on the tumors themselves. And we'll go into those details a little bit as well. Uterine sarcomas are also a different classification, where we could have a 1-hour lecture or 10-hour lecture on each of these individual brackets here, so I'm happy to answer questions. But leiomyosarcoma is a tumor that starts in the muscle wall and can be a very aggressive tumor, and that represents about 60% of all sarcomas. More rare subtypes include endometrial stromal sarcoma, which can have a low-grade, more indolent or slow-growing type, as well as a high-grade endometrial sarcoma or undifferentiated sarcoma. Some of these other subtypes are also kind of, we'll talk through a little bit about them in terms of like broad strokes in terms of how we treat sarcomas, and I'm happy to answer any other questions that arise. So one of the things that's really important is to kind of think about, like, how do we think about understanding the pathology report? So this is really central to me when I get the pathology report, whether it's from a biopsy or a surgery where a hysterectomy has been done. These are the things that I want to know about, and these are the things that we really want patients to be able to understand, and maybe even like ask your physician about, in terms of like, hey, you know what, I've been diagnosed with this, but like I'm going back and looking at this path report, and can you explain this to me? So it's really fair to kind of think about, you know, whenever you have a path report, whether it's again a biopsy or a hysterectomy, to kind of think about, like, you don't have to go into like too many details if you don't want to, but like asking some of these questions may help you decide if you're sort of an information gathering type, which I expect many of you are on this webinar, may help you kind of better talk the talk in terms of like really trying to figure out what answers to get. So one thing is the cell type. Is it a serous carcinoma? Is it an endometrioid? Is it a clear cell? That cell type, that general categorization that I just had on the slide before, would be important to kind of get to. The grade of the tumor. So if this is a high risk type, it'll always be grade 3, but maybe you have a low risk endometrial cancer and you actually have a grade 1 or 2. And then that may be, you know, this discussion is more relevant in case you are somebody who presented with tumor that had spread to the lymph nodes or spread to other organs, such as the liver or the lung. One of the other key elements of when we do a hysterectomy is to kind of get information about invasion into the muscle wall. So myometrial invasion, and you can see here a small picture where you can see that it's not just in the lining, but it's going depth in-wise. This purple and pink picture here shows how we kind of care about this 50% mark in the wall to kind of help us decide, is that a risk factor for needing other treatment? One of the things that we often look at is something called lymph vascular invasion, which sounds very strange and alien. And what that means is that within the tumor, down here in the most lower part of this little slide set, within the tumor, not spread outside of the uterus, but within the tumor, are there little blood vessels? And do those blood vessels have tiny tumor cells in them? Because that could be a pathway that tumor cells can leave the uterus and go elsewhere. So that's kind of a prognostic feature that we think about. Some of the things that we get in our pathology report also are the presence or absence, or the percentage perhaps, of the hormone receptors on the cell surface. So if you think about a cell having kind of the outside cell membrane and things jutting out of the cell membrane, there's all sorts of proteins that the cell displays on the surface of the cell that kind of helps kind of characterize it and give it its own personality. And so estrogen or progesterone receptors are often something that we think about for looking at that, because that may help us decide about treatment down the line or treatment in the setting of recurrence. So some of the other more complicated molecular testing that gets done, I'm going to go into depth here a little bit, and so bear with me a little bit. Here, one of the big categories of things that we think about are mismatch repair genes. So that's a set of genes in the cells that can actually be helping with DNA repair. And this is a certain mechanism of how cells that get damaged can repair themselves and go on to be normal. The presence or absence of mismatch repair genes, and those being present in a tumor, can be tested on the slides that we make from the tumor by something called immunohistochemistry. That's actually looking at stains of these slides and seeing if MMR is present or deficient. And I want you to kind of remember that, because we're going to be thinking about that down the line as we're thinking about treatment options. This all can be also related to something called microsatellite instability, or MSI. And again, these are markers and molecular ways of classifying tumors as either being MSI high or microsatellite stable. And this all refers to the mutations and the types of mutations that these cells may have within the tumor type. And again, sometimes this testing is done at the DNA level, and sometimes it's done at the slide kind of staining at the cell level. One of the other tumor testing that can sometimes be done is something called PD-L1. PD-L1 is also a protein that can be on the surface of a cancer cell and is a way that a cancer cell can try to avoid the immune system. And so that's important because there's some immunotherapies that are more effective if you have this biomarker PD-L1 testing or if you are MSI high. So those categorizations are really important to kind of think about, and we use those a lot. One of the other ones that we've used and in relation to learning again from the PATH report, what do we learn, is something called HER2. And those of you who may be familiar with breast cancer may have been exposed to understanding about a drug called Herceptin or trastuzumab. HER2 stands for human epidermal growth factor receptor. Again, another receptor sticking out on the cell lines of a certain amount of tumors, and we'll get through that. This actually has, because it was studied first in breast, has a targeted drug to be able to attack tumor cells that have this molecular marker. And so that's going to come up again when we're thinking about different types of treatments that are called targeted therapies that are based on like, what does the individual profile of your cancer look like? And so this is kind of a hodgepodge range of things. And we'll talk through a little bit more about sarcomas as well, but ERPR is very relevant to sarcomas. And the PD-L1 testing a little bit less so, but I think it's important to kind of think about the broad strokes of what we look at. I put this up here because now the classification has become even more complicated, and I didn't add slides because there's actually a new staging system that is being proposed and is being adopted by the international system in 2023 that actually looks at these classification types and says, hey, maybe some of our treatment decisions shouldn't just be the old-fashioned cell type or histology type, but it really should be the molecular and the DNA. This was based off of something called the TCGA, which is the Cancer Genome Atlas, which was created to kind of like profile all cancers, and uterine cancers were one of the cancers that were profiled. So the molecular testing profile actually was done on a group of endometrial cancers. So again, the subset of uterine cancers that are on the endometrial side, and they really came up with these very discrete types that actually behaved differently. So patients who were sort of had microsatellite instability, the MSI high patients, which were either the MMR deficient or MSI high. There were the POLE mutation patients. This is again a very specific type of mutation that actually did better. And there's some studies show that maybe we can decrease the amount of treatment we do if you have a POLE mutation. Then there's kind of the P53, which is again a pathology type of staining that we can look at or look at the DNA. And those actually are where some of the patients who have serous carcinoma or serous-like tumors shows up. And so this is important for you to just be sort of familiar with in the background, because your doctor may be thinking about some of these things when they're making their discussions about what to treat and everything. So I'm going to skip places a little bit to kind of talk a little bit about leiomyosarcoma. And I think in terms of other sarcomas. And so really the backbone for sarcoma treatment tends to be surgery. So hysterectomy is often really the first backbone, but many women will present with disease outside of the uterus so that we're actually using chemotherapy or other treatments first. And so I'm kind of putting this out there, but I think it's, in terms of like thinking about it, really surgery, resection, and sometimes re-resection of metastatic disease is often even a possibility. We really think it's important to think about imaging for the extent of disease. So making sure you've had either CT scans or PET scans to really establish at the baseline, like where is the cancer located. There's a little less data about aggressive upfront upfront chemotherapy because the data is mixed. There are some studies that have shown some potential, short-term survival benefit for patients who got a lot of aggressive chemotherapy, even if they were stage 1 disease, but it didn't actually find that it was necessarily as helpful because overall survival may not have been different. And so some patients really chose to kind of say, well, I'm not going to do chemo now, but if I recur, I will do chemo then. So there's a lot of like decision making that needs to be made based on like what the diagnosis is and where cancers are located. We do know that there's a higher recurrence risk for high-grade sarcomas. And so patients with sarcomas are often facing recurrent disease at an earlier time point and potentially a more aggressive outlook. And so it's something that we need to be thinking about when we're designing our options for treatment. Estrogen and progesterone receptor is especially important, especially in endometrial stromal sarcomas, which can actually be more indolent and maybe even be treated by anti-estrogen therapy, such as breast cancer uses the aromatase inhibitor therapy. Leiomyosarcoma can also have some component of it that will be estrogen receptor positive, and that might be important as well. So there's some newer things that are out there, such as fusion panel testing, RNA sequencing of tumors to really see if there are new targeted agents that are available, and really different chemotherapy agents that have been used, doxorubicin. I think I left off ifosfamide, but that's another one here, gemcitabine, toxotaxol, and there's some other newer targeted agents as well that we can talk through. But these are sort of some standard backbones for chemotherapy. I'm going to go through kind of like the model for treatment of high-risk endometrial, and this can really apply to a lot of different types of endometrial cancer as well. And so there's one model of like, hey, what are we going to add as additional or adjuvant after surgery? So patients with lower stage 1, maybe stage 2, high-risk endometrial cancer types, we often are pretty aggressive about treatment and often will treat with chemotherapy in the early stages. And so that additional therapy may depend on the molecular type and the tumor testing as well. But even in early therapy, a lot of people will give chemotherapy and like think about the role of radiation. When we think about radiation in general for uterine cancer, we know that it can be very effective for helping kind of local regional recurrence and lowering that. But in terms of like overall survival, we tend to be looking at kind of improvements that are related to either chemotherapy or, as we know, some of these other newer agents. Sometimes we're in a situation where we can't do surgery up front. And obviously as a physician, we want to kind of do surgery because we're surgeons, but we often kind of need to kind of think about what's all in our toolbox. And I often think about this in terms of saying, well, neoadjuvant chemotherapy, which is chemotherapy given prior to surgery, is really important for those uterine cancer patients who present with disease outside of the uterus. So this may mean that you have stage 4 disease because you have a serous carcinoma and it was metastatic to the omentum or other peritoneal areas. It may mean that you need chemotherapy because the amount of lymph node metastasis is too much to be able to take out surgically, or is located in the chest or something else like that. And that's a really critical thing that we're doing more and more these days because we are seeing higher stages, higher, more aggressive types. And it's important to kind of think about how that type of chemotherapy blends in, when is surgery sequenced in, followed by additional chemotherapy is the model that we use that's really mimicked after what we do for a lot of ovarian cancer as well. But it's really important to kind of think about like, what are these different elements, right? I think that but then I think the main issue is that like there's like maintenance therapies, there's ideas of like pembrolizumab, Herceptin, HER2 positive tumors, as well as kind of like the role of radiation. There are options for recurrent disease that we'll talk through as well. So I think some of the things that I want to kind of get into as well is some of like the other studies that are out there to kind of think through what are the things that we're looking at for endometrial cancer, sort of like all comers in terms of like people who are diagnosed with like multiple different types of endometrial cancers, as well as like more type specific. So one of the studies that came out that really started to really change the landscape and really get FDA approval for some of these newer drugs was actually kind of looking at a 2-drug combination, lenvatinib, which is a tyrosine kinase inhibitor. So when I think about these targeted therapies, oftentimes these are targeted therapies that are looking at the cascade of what has to be either turned off or turned on when your cancer is activated. And these are looking at like targeting those. pembrolizumab, which is a PD-L1 inhibitor, in terms of being able to blockade some of the ways that cancer cells can actually evade the immune system. So this study looked at the role of this combination in patients who had advanced or recurrent endometrial cancer and showed a survival advantage for patients who were in the category that immunotherapy alone, because they were proficient in MMR, as we kind of described before, actually did show a benefit in terms of overall survival. And so this was really important in terms of thinking about like who benefited. The patients who have deficiency in MMR may benefit actually with pembro by itself and not that much of a higher rate with the addition of the lenvatinib. But I think it's really important in terms of like thinking about like, how we kind of change what drugs are available. And so thinking about lenvatinib pembro, I think most people who have a recurrence in their cancer will eventually be seeing this drug, quite honestly, drug combination that is. So one of the more recent studies that was published this year was really looking at the idea of pembro plus chemotherapy in a more upfront setting with stage 3, stage 4 disease. Like, do people do better if we add this immunotherapy to the chemotherapy landscape? And so I think that those are things that are really important. And this study that was published did demonstrate that the overall progression-free survival, which is kind of a thought process of like, how long did it take for somebody to kind of progress off of a therapy, was really improved compared to the group that got the placebo. Now, everybody got chemo as their backbone, but a portion of the group got the pembrolizumab and a portion got the placebo. And in conclusion, the authors really concluded that the progression-free survival was significantly improved with the addition of the pembrolizumab to standard chemotherapy. And I think it's not a completely perfect study, because a lot of these studies do take into account like endometrial cancer included serous, but did not include carcinosarcoma. So I think there's a lot of like different things that we need to think about on how we extrapolate data and how we make decisions about individual patient care, right? But I think this is a really important study that may move the pembro into more frontline setting and is now a part of the NCCN guidelines. So talking through a little bit about serous carcinoma of the endometrium. So 5 to 10% of all uterine cancers, but unfortunately, maybe up to 40% of deaths uterine cancer. We've often talked about some of the risk factors, which include tamoxifen use, older women, especially Black women, breast cancer history, and hereditary cancers are a little bit more linked to serous carcinoma of the endometrium. A higher stage of presentation, and truly a backbone of carboplatin and Taxol that's going to be used for early stage and advanced stage. And then now with advanced stage, we think about other targeted therapies. So really importantly, 20 to 40% of these may actually have the HER2 expression on the cells, and Herceptin, which is a monoclonal antibody that I mentioned earlier, that's been known since 1998. It's only been recently that we've actually been using this to think about using this for endometrial cancer, and in particular serous carcinoma. So one of the important studies that was done was looking at a randomized trial, looking at patients with serous carcinoma who did have HER2 positive, and they did have a benefit to chemotherapy alone in terms of their survival. So this is actually so important as to why we're testing these things up front, because we want to introduce them early when we want to be able to kind of like make sure that patients are getting access to these drugs. And that's actually a really important point, because if you're not getting access to all of these drugs up front, you may be missing a window of time that we want to be able to use these, at least in the initial setting. I think that that's important to kind of think through in terms of like when the sequencing of all these drugs is made as well. And sometimes this happens in the upfront setting, and sometimes it happens when somebody's recurred. So thinking a little bit about carcinosarcoma, and this has been a really challenging, a very challenging, critically important cancer to focus in on in terms of it. For a while it was like lumped with sarcomas. We know that it's an endometrial type of cancer that may have undergone some type of like transformation to have these both elements of both a gland issue and a sarcoma or muscle component. But again, it's still all arising from the lining itself. It is increasing almost by 2% each year, and it's a cancer with a significant disparity, especially with Black women. So I think, when you look at like the MMR status and the immunotherapy status, only about 7% of patients are going to have like MSI high or DMR and be eligible for thinking about like using immunotherapy by itself, right? Chemotherapy, the additional targeted therapy, is going to be really key in terms of like talking through like HER2, which has actually been really looked at and now is mentioned at NCCN guidelines. So we've been able to really get this for patients who have HER2 positivity in their tumors. There's actually some interesting data looking at some of the newer HER2 targeted agents that are looking at overexpression in breast cancer and how we can kind of move those agents over for carcinosarcoma as well. And so I think that's going to be really important. And like right now we're using it on sort of like a day-to-day basis for thinking about how do we get like authorization for like one patient at a time, but I suspect that we'll start to see those trends as well. And then thinking about radiation for local control, carcinosarcoma is the one sarcoma that we often think about radiation for, both in terms of like post-operative radiation, as well as like more targeted radiation for patients who've had recurrent disease as well. And I think the issue is that we really, we need more study on this. Like we need more people to be, thinking about how we do this. Like I'm particularly excited. One of my partners, Dr. Kernit at University of Chicago, is actually, recently awarded like a career development award, really to focus in on immunotherapy and carcinosarcoma and targeted agents. And so this is where we need more really data from the continuum, the basic biology, the translational research, and the clinical trials, as well as kind of like really pushing for carcinosarcomas to be included in like the whole group of endometrial cancers that's included. I talk fast, so I've gone through a lot of slides. The last thing I just want to kind of think through is like, decision making. We really do have to think about like molecular testing if it hasn't been done before. Next generation sequencing if it hasn't been done before is another terminology that you will use for thinking about like tumor testing. We want to keep the quality of life and the toxicity assessment of each of these drugs really high, because we really want people to be living well if they're going to be on and off for treatment, right? The time burdens of therapy choices, the psychosocial support, and really thinking about like the smart way to sequence your therapies is going to be kind of something that I think about in terms of when I'm thinking about a patient and I think about their like longer term trajectory. And I think that that's, is, a really important aspect of thinking through that we really want to work with patients directly to like say like, okay, this is a marathon and how are we going to get the best outcomes based on like what we know. So I'm going to end here and stop sharing slides. I see that there's a lot of Q&As, but I'm sorry I wasn't able to look at them when I was in the session. So I am happy to go through questions, and I do recognize that some of you are really experts in this field through your own experience, and so I know it's always hard to capture in a webinar everything, and I'm happy to kind of take questions and go through things with Kitty, if you can kind of be my guide in there.
Yes, absolutely. I will guide everything with the Q&A. Thank you so much, Dr. Lee. There's so much information. It's really great to hear all about this. So we're going to start the Q&A. Thank you to everyone who pre-submitted questions when you registered. There were quite a few. And you can still submit questions now in the Q&A section at the bottom of your screen. And we'll try to get through as many as we can, but we may be somewhat limited by time. But let's get started. I'm going to start with a couple of general questions because there were quite a few, and then we'll go into the more specific. Yeah. How many years from diagnosis does risk of recurrence diminish greatly?
Yeah, I mean, I think it varies a little bit with the general high risk endometrial cancer types and some of the higher grade sarcoma types. Most recurrences will usually happen in the first like 2 to 3 years. And as you're getting beyond like a 5-year range from your completion of your treatment, I think that risk does go down. There are some cancers that are kind of the low-grade endometrial stromal sarcomas that actually have like a more indolent risk factor, and that they can kind of show up again even like years down the line. So like just being like aware of symptoms, doing surveillance exams. There's not a really great studies on like whether or not to get CT scans done too frequently or those kinds of things, but but most of the time I would say it does go down over time, especially after the first 2-3 years.
Okay, great, thank you. And what are the most common signs one should look for recurrence of metastasis? I think we've gotten that question a lot.
So tricky. I mean, this is such a critical issue. I mean, unfortunately, there have been so many studies that show that like doing a CT scan every so often may or may not help for sarcomas, and for some of the aggressive types, we tend to do scan, especially if you had a higher stage at the time of presentation. We will sometimes do CT scans to do surveillance. But the symptoms that people often will report would be potentially vaginal bleeding that may reflect a localized recurrence, but again, not all vaginal bleeding is recurrence. Sometimes it's like major changes in bowel or bladder. Sometimes it can be nuanced pain symptoms. Sometimes it's something that's found on exam when you go in for your surveillance exams. And so I think the range, if you are experiencing something unexplained, which just doesn't feel right to you, like whether it's weight loss or changes in your appetite or some other kind of like significant fatigue that you can't really explain, or, it's worth talking to your GYN oncologist to be like, okay, what should we do? Do we need to do a workup? And they can maybe either counsel you about, no, I don't feel that we need to do anything right now, or yes, we can do this, and kind of fine tune it for the cell type that you have.
Great, thank you. This is an interesting question because I know this is done in breast cancer, but I haven't heard much about this with uterine cancer. Somebody's mother went through menopause at 54 and died of an aggressive uterine cancer. She's 53. Should she consider a hysterectomy?
Yeah, so, not the majority of endometrial cancers or uterine cancers in general will not be hereditary. So it's really probably pretty low of like all people with uterine cancer. It's probably only like 3 to 5% will have some kind of hereditary reason. If you have like a single family member who has endometrial cancer, it probably does increase your risk slightly, to that population. The hard part that is that on a population level, there's like no data to suggest that like you going through the individual risk of a hysterectomy would make sense for you per se, because but everyone's really different, right? Like people feel differently about it, but I generally wouldn't necessarily recommend that you need that if you haven't had like symptoms such as irregular bleeding or something like that. Now, definitely being aware of bleeding, discharge, pain, anything else, and prompting that with your gynecologist to like think about biopsy or ultrasound are really important.
Thank you. Yeah, that makes a lot of sense. I'm going to switch over to some questions about clear cell and serous carcinoma because we've had quite a few about those. Yes. Clear cell. Now, just to clarify a little bit, what new immunotherapy works best for clear cell?
Yeah, so I mean, I would say the clear cell tends to unfortunately fall in a category that there are not like a lot of like newer markers that are automatically targeted. People have been looking at like targeting some of the pathways, including like the PI3 kinase pathway, including all these different pathways that may be similar to what renal cell carcinoma gets, because those clear cell carcinomas in renal, in kidney, and uterus look very similar, quite honestly. So that's one pathway. But I think the clear cell carcinomas generally get lumped into the idea of like being eligible for immunotherapy at the setting of like a recurrence in the combination factor of the Lenvima and the lenvatinib and the pembrolizumab factor. You can get PD-L1 testing, but the testing results of the immunotherapy is not as high as some of the other endometrioid types of high-grade cancer. So it kind of varies. And clear cell carcinoma equally is one that, there has been kind of mixed picture about like maybe using like radiation as well. And maybe, there's some idea, like, is it as chemosensitive as the other types? I think among the high-risk types, serous carcinoma tends to be the most chemotherapy sensitive in general, but clear cell carcinomas of the endometrium, we still do use that like upfront, like higher rate of like giving treatment even in early stage disease.
Thank you. And actually, this leads into questions about serous. What is the difference between clear cell and uterine serous carcinoma?
Yeah, so the difference is really kind of, I guess maybe I'll share screen, but the difference is really a little bit about like which genetic testing, or not testing, which molecular pathways are kind of like the cause of the cancer happening and which ones are turned on. So that can often be one of the things that we're seeing in terms of like what we're looking through. And so that's one way that we can kind of think about like serous carcinoma, for example. Like serous is often driven by P53 mutations. And so that's like a really important thing that we think about, versus like, clear cell carcinomas can sometimes be driven by this like ARID1A mutations. And so there's some targeted therapies that are in clinical trials for those types of drugs. And so I think it's the differentiation is the look. So I can share screen for a second if you want. I'm not sure if that you want me to go back and forth, but I'm happy to, I don't know, it might be a little too complicated, but if I can, the difference in the diagnosis is made at the level of the pathologist and then is backed up by the molecular testing, I guess.
Okay. Yeah, no, that's okay. Thank you though for that offer. What new research has emerged related to the higher incidence of uterine serous tumors for African-American women? Because I know this is a big thing.
Yeah, I think this is a really critical area. So, I mean, some of it became because we've actually are just better at diagnosing these tumors. And so before, when we didn't have all of the molecular pathology, everybody was just kind of lumped together as like high-grade cancer, like whatever. We didn't really know about it, right? So some percentage of that is probably like a little bit of reclassification. And now the pathology is being honed in to try to find it, actually. And so, but I think that there's a lot of features that are related to that. So there's definitely this serous cancer increases with age. So as the population ages, right? That's one factor. Even though we often think of the type 1 low-grade cancers being more kind of driven by obesity and inflammation, these other tumors are also inflammatory driven. And so we think about like these other stressors and that can be related to the environment. It can be related to obesity, but maybe not at the higher levels of obesity. There's just a lot that we don't know about like the mechanisms that are going to cause those changes enough to kind of warrant it turning into a serous carcinoma, quite honestly. And so I think it's really important to be thinking about like the genetics. And then this is where like the studies that are done in the biology of all of these tumors is really important in terms of like having enough basic and translational scientists who are looking at this and looking at it with diverse patient population samples. This cancer, serous carcinoma, and some of the other high-risk types like really align when you look at like some of the genetic mutations a little bit in the same way as like triple negative breast cancer happens, and so it's a similar idea of like, what is it about this, are we missing kind of like like social and structural. There's some really interesting data that people are looking at, like what are kind of like the modifications that can be affected by like, racism related stress or socioeconomic stressors or poverty or, different things like that mediate that. But it's not like it's all race and socioeconomics, right? Like it's not that easy to put that into a box. And a lot of it is like irrespective of your like economic status, for example, in terms of the rates that we're seeing. So.
And with high-grade serous carcinoma, after radiation, chemo, is there any recommended maintenance?
So I think the recommended thought process is that for patients who have early stage disease, like it hasn't really been pushed into the maintenance phase yet. I suspect that people will start to look at that. But in patients who have more advanced stage disease, the idea of adding the Herceptin, especially if you are HER2 positive, only if you're HER2 positive, is a maintenance option. So that's actually getting a year of Herceptin after you're completed your chemotherapy has been shown to improve survival.
Okay, I'm going to veer a little into some other of the rare cancers we discussed, and we'll go back if we have time to some of the others. Somebody asked, uterine sarcomas get surveillance scans every 3 months routinely, and they mentioned GCS as a prognosis, but that they don't get the same scans, or I'm not sure if I'm
assuming
understanding.
that person is referring to like just sort of like gynecological carcinosarcomas as a whole, but maybe that question in could just make sure that I'm saying that correctly. I'm assuming that that's what you mean by GCS, but somebody can ask that.
I think so.
Yeah. Okay. Yeah. So, I think that differs. I mean, I think because uterine sarcomas have still a little bit of a higher risk of recurrence in like a very short interval time. People tend to do the surveillance, and that's been kind of like similar to what like the other sarcoma literature has done. Carcinosarcomas, because they get lumped into like sometimes having like CA-125 as a marker, sometimes kind of being lumped in the endometrial world or the ovarian cancer world, depending on the disease site of origin. It's not as consistent. You know, when people have studied surveillance patterns in high grade uterine cancers, like we did a retrospective study at our own institution, and we really found that the only thing that really made a difference was like the patient's symptoms and the patient's like any physical exam, and survival really wasn't affected by the scans. Now that's a lot of older data that did not have the advances of like thinking about targeted therapy. So you could argue that that might change, but I think it's, me personally, I think it's a personal decision making with the individual patient that needs to be made and clarified about what your individual like standard is going to be. Like, I don't think it's great to kind of say nobody should get scans, but I think it's something that like we really need to kind of define. And sometimes that's based on the philosophy of the patient. Some of my older patients don't want scans and they're like, I'm 85, I don't want to scan anymore. And some of my patients are like, look, like this is something that, you know, I want to do as part of my surveillance. And we kind of come up with the package, if that makes sense.
Yes, thank you very much. Is there consideration for use of immunotherapy before recurrence to try to avoid recurrence?
I think that there's, so the way immunotherapy is used right now in uterine cancer is definitely using it in the setting of a recurrence of endometrial cancer. You can either get immunotherapy alone or immunotherapy paired with lenvatinib, dependent on your MMR status. So there's one group of people who can get that, right? Then there's a group that now are getting diagnosed with maybe advanced stage at the time of their surgery that we're saying, okay, hey, you had your surgery and now we're going to do chemotherapy. And now, hey, we have this new New England Journal paper that shows adding pembrolizumab or adding dostarlimab, another one of the immunotherapies, to chemotherapy will help improve how you're doing. So those are kind of in that preventive range, right? So a small group of those patient studies that actually had stage 3 disease and may not have had like measurable disease, meaning like we couldn't see any disease, but we knew they were high stage. So those there may be benefit on that.
Thank you very much. There was a question here about CA-125, which we know is used very commonly in ovarian cancer. And as someone had never had a baseline CA-125 prior to surgery, she now takes a blood test every 3 months for CA-125 and wondered if the test was pointless due to the lack of baseline. But also I'm kind of wondering how you feel about it for uterine cancer in general, because I think it hasn't been proven to be as effective.
It's not perfect, right? So we use it, but we know there's limitations. And that's where I think we think through like what are the like options for you know, before surgery, if you're able to get it. Not all insurances or Medicare will cover that all the time for endometrial cancer. So there's a whole other ridiculous thing about that, but I tend to use it in my high grade cancers, particularly serous or carcinosarcoma, when people have had a higher stage at presentation, and I kind of follow it once a year. But I warn people, like, I don't know if it's a great test. It's not like if you have a normal CA-125 and you have some symptom that you come up with that I'm going to be like, oh, but your CA-125 is normal. We're going to have to use all of those things. Like, how's your exam? How are you feeling? Is there any, you know, new symptom that we need to work up? And so it can be an adjunct, but it's a less than perfect adjunct, unfortunately.
So the data shows that new cases are increasing. Are recurrences also increasing?
You know, that's a good question. I think it's more that, like, because the rate of increase has been higher in the subtypes that actually have higher recurrence risks, if that makes sense. So everything's increasing. I don't know if we can separate that out.
Thank you. What areas does uterine cancer usually metastasize to?
So serous carcinomas tend to metastasize, as do carcinosarcomas. A lot of times we'll see cancer within the peritoneal cavity or the abdominal cavity. They can also metastasize along the lymph node, chains that are either in the abdomen or in the chest, or it can show up in the lung as like separate lung nodules or even liver nodules. But those are kind of some of the more common areas, like a lymph node characterization or something like that.
Okay, great. Let me go back to, because I didn't ask you about some of these others that were pre-submitted. Uterine adenosarcoma. Could you tell us a little bit more about that?
Yeah, so uterine adenosarcoma is it's a sarcoma type. It arises from the muscle wall. It's sarcomas are a little bit harder to diagnose because some people won't have a lot of irregular bleeding as their symptom. So endometrial cancer, which tends to have bleeding right away, like is a little bit easier to diagnose. Adenosarcomas can sometimes present as like a mass that's coming out of the cervix or bleeding because of the way they distribute themselves. The decision making is usually surgery. Like surgery is kind of by default the standard to like have a hysterectomy, and then the decision about other treatment and the risk of the cancer coming back depends on the sarcoma itself. So some of those sarcomas within adenosarcoma, when you look at the sarcoma part of it, will have high risk features, that they have a lot of like turnover. The cells are rapidly dividing. There's some, categories of like how many cells of the group that you're looking at are rapidly dividing, or how ugly the cells are, that will help us decide, is this going to be an adenosarcoma with sarcomatous overgrowth and may behave more aggressively, and we may lean towards radiation or other treatment, or is it one that doesn't have those features and the sarcoma actually looks very bland and very low grade and we don't do anything? So it depends a lot.
Thank you very much. And I think I didn't ask any questions yet about uterine carcinosarcoma. A few people asked about
I see those in the chat room. I'm trying to make sure we get to all of those things.
New research, new treatments, at survival rates. People are asking several questions about that.
I think it's hard because I think, survival is such a difficult thing. Like we have like generic survival for type 2 cancers, and then you have survival by stage, and then even within stage, different, like when the when we kind of look at stage, for example, take somebody who's a stage 3, right? So that means that there's nodal involvement. And so that could include somebody who has like microscopic nodes that were fully resected, or it could include periortic nodes that like were never able to be resected and we had to use chemotherapy for them, or, so it kind of has this like wide range of things that can happen. So I think in general, we do worry that at a 5-year mark, patients who have, stage 4 disease at the time of their presentation, most of those women will not be alive after 5 years, right? So a majority of patients, unfortunately, will pass away, and the survival for a very high risk type at a high stage may be really low and be between 5 and 20%, right? It may be depending a little bit on like what was removed at the time of surgery. Was there any residual? There's a lot of those nuances. And then I suspect that we'll start to see differences as people are using these other things like Herceptin and immunotherapy. I think that's going to change our survival landscape. And that's been really positive because the immunotherapy has kind of had some really interesting data about kind of changing how people respond to other treatments down the line too. So there is this hope that we're kind of moving in the right direction.
No, that's great to hear. And I know there have been so many advancements in recent years. And so that's really terrific. Let me just see if I can get to one more question.
I know there's a lot of really good questions. I'm not even sure how, maybe you will have to collect them, Kitty, and like answer them in a different way or post them.
Yeah,
that might be nice to work with.
We'll figure something out. No, we'd love to, because there are so many. I think, let me just get to one more. What do you think about the use of low dose of steroids when on immunotherapy?
I have not used that. I will say, like, we've used the steroids during immunotherapy only when people have had a side effect that had needed management, such as a toxicity related to lung or diarrhea, or like different things like that. I'd have to really take a deeper dive in terms of, like, does that blunting by the steroids of your immunoresponse like cause some kind of change in how well you do. One of the really fascinating areas that I'm really intrigued at looking at related to immunotherapy is the microbiome and how diet can actually affect your efficacy of your immunotherapy. And so there are some interesting studies that are first coming out in melanoma, and I'm kind of really, I don't know enough to kind of say, oh, they have this diet or that diet, but people really looking at, like, the diversity of your diet in terms of, like, is that going to be something that actually improves response rates to immunotherapy? So there's some studies that are going on in colorectal and in melanoma that I've seen, and I must probably have to admit, I'll have to, like, look at that into uterine, where they're looking at, like, how diet can modify your efficacy of your immunotherapy. And so that's something to be thinking of, in terms of things. So that's kind of a whole other discussion.
That's a whole, right. Actually, that just leads me to ask one very quick, well, maybe the answer won't be so quick, but do you generally recommend dietary changes after someone is diagnosed? Or?
I think I tell people, like, the same things that I should be following, that we should all be following, whether you're a cancer survivor or, is, like, avoid the extremes, things in moderation. And diet quality more than, like, calorie counting, right? So, like, your diet quality of, like, less processed foods, more foods that require less, like, like when you look at the box, if it can stay on your shelf for like 100 years, it's probably not the thing we want to put in. But so I think diet quality of, like, less processed and less added sugars is, like, my overall thought process. But there's not, like, a specific diet that I think you have to do the Mediterranean diet, or you have to do, like, a low carb diet. And you can also cheat, like, nothing's going to happen. Like, that's not going to be the make it or break it, I think. But in general, for all of us, I think people tend to feel better with that type of balanced diet,
Thank you.
Yeah.
Thank you so much, Dr. Lee.
Questions. I don't even know what to say. I see one on circulating blood tests. I'm hoping that will become something down the line. I think that the studies are really preliminary in any of the uterine cancer models. Yeah, there's a lot out there. I'm more than happy to, Kitty, work with you to figure out how to get some of these, groups of questions answered.
That sounds great. No, we'd be so appreciative of that. And thank you so much. It was a lot to cover, and we really appreciate your diving deep into.
Thank you so much for having me.
No, thank you. And thank you to everyone for participating. Thank you for submitting questions. We will, Dr. Lee and I will talk more, and we'll figure out
something out. Yeah.
To get more of them answered. And please make sure to check out SHARE's upcoming educational programs and support groups, and follow us on social media as well. And please take a moment to fill out the survey at the end of the webinar. The survey will appear in your browser when the webinar ends, and the link will also be included in a follow-up email, and all the surveys are anonymous. So that concludes our webinar for today. Thank you so much for joining us, and have a great rest of the afternoon. Thank you again, Dr. Lee. We're so appreciative.
I'm so excited. I can think of a lot of new topics that we can cover.
Sounds great.
All right. Okay. Take care, everybody.